Hi, I'm Bobak Arshi. I'm an attending in the Neuro ICU, and I'm going to talk to you about traumatic brain injury and intracranial pressure. When I think of TBI patients, I first think of them in the context of classification, and this helps me think about the patient before I go see them. The ways I classify a TBI patient are with imaging, this is commonly with the CT head, Glasgow Coma Scale, and closed or open injuries. TBI can be a heterogeneous disease with different presentations, as can be seen on CT head. All patients who come to the hospital will get an HPI, or if they are not conscious, they'll have descriptors by EMS that helps us determine what the mechanism of injury was. Once they come to the hospital, they'll commonly get a CT head, which helps us to further stratify what type of TBI they have. TBI can present as a subdural hematoma, which commonly is related to tearing of the bridging veins. Here in this CT, we see a crescent-shaped extraaxial hematoma. Here we see some brain compression. There's subfalcine herniation and effacement of the lateral ventricles. Subdural hematomas are very common in isolation and can also be present with other components that we'll see in a moment. TBI can also present as an epidural hematoma. Epidural hematomas commonly happen due to injury to the middle meningeal artery. These can be associated with skull fractures as well. Other mechanisms of epidural hematoma include dural sinus injury. In this CT, we see a common classic picture of an epidural hematoma that really respects the sutures of the skull and can commonly be screened with the CT head. TBI can also present as a cerebral contusion. Cerebral contusions happen due to trauma of the brain parenchyma, either because of proximity near bony prominences or the rigid falx. Common locations for a contusion include the frontal lobes or temporal lobes. And here we see an image of bifrontal contusions. And you can tell that a lot of the contusion is by areas of the bony prominences of the sphenoid wing and the rigid falx. And so commonly what happens is if there's a blunt injury, the brain can in and of itself be injured by the skull by hitting these bony prominences or rigid parts of the brain. Another descriptor we use to talk about cerebral contusions is coup contra coup injuries. Coup contra coup injuries happen when commonly you fall and hit your head, and at the impact site you'll have an injury, and then contralaterally, due to either trauma with the rigid structures or other mechanisms, you can have a coup contra coup pattern. A common coup contra coup injury that we'll see is a patient who falls backwards and hits the back of their head and has an injury or contusion at the occiput from the actual injury site. And then due to trauma because of the sphenoid wing or rigid falx, they'll also have frontal lobe contusions. Traumatic brain injury can also manifest as a traumatic subarachnoid hemorrhage. Traumatic subarachnoid hemorrhage is important because from research we've learned that traumatic subarachnoid hemorrhage is independently associated with a higher mortality for TBI patients. And here in this image, we see a picture of a cortical subarachnoid hemorrhage in the right sylvian fissure and the cortical sulci. The other thing to consider with subarachnoid hemorrhage is if it's not an obvious TBI pattern, you may want to consider ruling out vascular malformations, as patients with aneurysms and AVMs can present with subarachnoid hemorrhage. TBI can also present as diffuse axonal injury. Diffuse axonal injury commonly happens with acceleration-deceleration injury and commonly presents with imaging of microhemorrhages at the U fibers, brainstem, or corpus callosum. In this image, we see some microhemorrhages at the subcortical and gray-white junction, as well as the splenium of the corpus callosum. As is commonly the case in diffuse axonal injury and can be the case in TBI in general, the imaging may not look that bad, but the patient can look very sick. And this is true with TBI in general, where you may have imaging that's not that severe, but a patient looks very sick, or vice versa, where the imaging looks very bad, but the patient can look okay. And these differences in consciousness is captured commonly with the Glasgow Coma Scale, which we'll talk about in a moment. When piecing it all together, multiple types of TBI can present in a single patient. In this patient, we see a left convexity, small and very thin crescent-shaped subdural hematoma. We also see bifrontal subdural hematomas and a little bit of subdural hematoma layering along the falx. In addition, we see a right frontal cerebral contusion and some smaller cerebral contusion in the left frontal side, as well as cerebral contusion in the left temporal lobe. It's not uncommon for TBI patients to have one or many components seen on imaging. The other way we'll classify TBI patients is with the Glasgow Coma Scale. And so initially when the GCS score was created, it was created as a means of communication for specifically TBI patients. Glasgow Coma Scale is used to differentiate severity of TBI, where patients with a mild TBI are classified with a GCS of 13, 14, 15. Moderate TBI is classified as a GCS 9 to 12. And then patients with a severe TBI classified as a GCS less than or equal to 8. How do we calculate the GCS? GCS has three categories: eye opening, verbal response, and motor response. Eye opening is a 4-point scale. If the patient opens their eyes spontaneously, 4 points. If the patient opens their eyes to voice, 3 points. If the patient opens their eyes to painful or noxious stim, 2 points. And for patients who don't open their eyes, 1 point. Verbal response has 5 points. For patients who are oriented and communicating, they'll get the full 5 points. For patients who are disoriented, 4 points. For patients who have irregular speech, 3 points. And for patients who are moaning or have incomprehensible speech, 2 points. And for patients who are intubated or not speaking, 1 point. And then motor response happens on a 6-point scale. Six points for obeying commands and moving fully. 5 points for localization. 4 points for withdrawal. 3 points for flexor posturing. 2 points for extensor posturing. And 1 point for no movement. And so when calculating the GCS, we want to calculate all three classes and look at eye opening, verbal response, and motor response. And this will help us determine if a patient has a mild TBI, moderate TBI, or severe TBI. One of the common questions I'll get for trainees rotating through the Neuro ICU is, how do I differentiate between localization, withdrawal, flexion, and extension? Sometimes it can be challenging. Most patients who are laying in a hospital bed will lay with their arms to their side. For starters, I always encourage trainees to put the arms in a neutral position in the patient's lap. This will allow you to see small changes and fluctuations in movement. And then commonly for patients with a low GCS, you're going to have to administer a noxious stimulus. We commonly administer a central stimulus. Localization occurs if someone, for example, pinches your left shoulder and you move your right arm towards that left shoulder to grab that painful stimulus. That would be considered localization. Withdrawal, if someone pinches your nail bed and you try to get your hand away from it, that could be considered withdrawal. Flexion commonly happens in a stereotyped fashion where the arms come up medially. And then extension happens when the arms rotate externally, like this. Even a more nuanced point, and sometimes a more difficult point to determine, is what the difference between withdrawal and flexion is, because sometimes they can look the same. What I'm always looking for is complex movements out of a single plane that may be suggestive of withdrawal versus repetitive movements in a single plane that may be more reflective of flexion. Flexion commonly happens in a single plane. Commonly, the arms don't go above 50% of the way to the upper body versus flexion, which can happen in multiple planes and can come further up. And so it's sometimes difficult to determine the difference between localization, withdrawal, and flexion. So consider, for starters, putting the arms in a neutral position. And then the third way we classify TBI patients is whether they have a closed injury, which is blunt trauma. This is when the dura is intact, and common mechanisms of injury for blunt trauma include motor vehicle collisions or falls, or whether a patient has an open injury, which is also termed penetrating trauma, and this is when you have dural penetration. Common examples of an open injury or penetrating trauma is a gunshot wound. And so when piecing it all together, you can consider these three classifications when screening or writing the diagnosis for a TBI patient. For example, a 65-year-old male with a severe blunt trauma characterized by a subdural hematoma, bifrontal contusions, and small subarachnoid hemorrhage. Contrast that with a patient who's an 85-year-old female with a blunt trauma, mild TBI, characterized by a small subdural hematoma over the left convexity. In your mind, when you're approaching each of these patients, you can think about what the differences between these two may be. I get asked a lot at work, what's the difference between TBI and concussion? Well, concussion is often used synonymously with mild TBI, and it's a term that's commonly used in the outpatient setting or in the sports setting. Concussion can be used more specifically to describe the characteristic symptoms and signs experienced after mild TBI. And other thing to consider is it's really on a spectrum and a continuum with TBI, where you have severe TBI all the way to mild concussion and everything in between. And so while we commonly talk about these things differently, they really are a continuum of the same disease state. However, for the sake of inpatient medicine, we're commonly talking about TBIs, and while patients may have concussions, that's commonly a disease that's more commonly treated in the outpatient setting. How do we treat TBI patients? Some of the basics of TBI treatment include prophylaxis with Keppra for 7 days, and this is because of the incidence of seizures in TBI patients. TBI patients can have seizures at the ictus of injury, so right when they hit their head, they can have seizure. They can have seizures early that occur in the first 7 days, or they can have seizures in a late phase, and this is after 7 days. Important to note, when patients have seizures at the ictus or early seizures, so before 7 days, it doesn't portend a higher incidence of post-traumatic epilepsy. However, for patients with late seizures after 7 days, they may have a higher incidence of post-traumatic epilepsy. We treat all patients with prophylactic Keppra just to reduce the incidence of in-hospital seizures. For patients who have not had seizures, we'll commonly stop the Keppra after 7 days. However, for patients who have had seizures, it's not uncommon to continue the medicine Keppra on discharge and have the patients follow up in the outpatient setting to stop it. In addition, we'll maintain a systolic blood pressure greater than 100, we'll maintain normothermia, and we'll maintain oxygen sats greater than 92%. We do these three things because hypotension, hypothermia, hyperthermia, and hypoxemia are all associated with poor outcomes. And so we try to make sure that the blood pressure is normal, the temperature is both below 38.5 and above 36, and the patient is not hypoxemic. We'll ensure the patient's head is midline and neck is in alignment with the C-collar if one is indicated. And we'll be sure to start nutrition by hospital day 5. We commonly do this in conjunction with our nutrition team because TBI patients often have a higher caloric requirement. Severe TBI differs from moderate and mild TBI in some aspects. Severe TBI patients, by definition, will have a GCS of less than or equal to 8. So these patients are much sicker by definition and will come in often less awake and less aware. In these patients, we want to make sure that they're protecting their airway, and if they're not, we want to establish an airway for them. We want to make sure the ABCs are attended to. And for these patients who are herniating, we want to make sure to emergently treat herniation, whether that's by surgery, osmotherapy, or hyperventilation. And then if indicated, we want to be sure to insert an ICP monitor. I want to differentiate the management of severe TBI versus the management of patients with a GCS less than or equal to 8 with other disease states. Sometimes we'll take considerations differently if a patient has an ICH with a low GCS versus a TBI with a low GCS. So just important to note, these rules don't necessarily apply to all patients who have a GCS less than or equal to 8. This is really specific for TBI. What are indications to measure ICP? If you have a salvageable patient with a GCS less than or equal to 8 with abnormal CT head, or GCS less than or equal to 8 with a normal CT head and 2 of the following: age greater than 40, systolic blood pressure less than 90, or flexor or extensor posturing. Again, I want to mention this is really specific for traumatic brain injury, as the indications for ICP monitoring or CSF diversion is different for different diseases, ranging from ICH or subarachnoid hemorrhage. For patients with TBI with a GCS greater than 8, a neuro exam can guide treatment, and we commonly won't place ICP monitors for these patients. The Monroe-Kelly doctrine is really important when it comes to measuring and managing ICP in TBI patients. It dictates that the intracranial compartment is limited by the skull, where any increase in the volume, so blood from a TBI, is accompanied by a compensatory decrease in volume, either CSF, blood, or brain. So what are the 3 components of the intracranial compartment? Brain comprises 80% of the space in the intracranial vault, blood 10%, and CSF 10%. So anytime we have a mass lesion or a TBI with blood where it's not supposed to be, the first area or part of the intracranial vault that's displaced is CSF. And what happens is CSF within the skull will get displaced into the lumbar thecal sac. Once the CSF has been displaced, if there is still a pressure gradient or a pressure problem, the next component that will be displaced is blood, and then brain. And when brain gets displaced, owing to a mass lesion or TBI, it's commonly referred to as herniation, and this can manifest as uncal herniation or central herniation. Commonly, when we're managing TBI patients, we're making sure to prevent secondary brain injury. So it's of utmost importance to keep in mind if someone is having herniation, midline shift, we need to intervene in order to prevent secondary brain injury. How do we measure ICP? In our hospital, ICP is commonly measured in 2 manners. One, an intraparenchymal bolt, or an external ventricular drain. However, important to note, there's other ways you can measure ICP. So you can have an epidural transducer, you can have a subdural catheter, or you can have a subdural bolt. And these ICP modalities may be used in other hospitals, so it's important to keep in mind that they exist. However, I'll focus on the modalities that we commonly use here. An intraparenchymal catheter or intraparenchymal bolt or Camino can commonly be used for TBI patients to measure ICP, as can an EVD. So when would you consider to do one versus the other? TBI is one of the few diseases where we place bolts, and that's because we commonly just need to measure ICP. So if the main indication for placing an ICP monitor is just to measure ICP, a bolt is a great option. It sits in the parenchyma, it can be done at the bedside, and it can give you valuable information about ICP. When would I consider doing an EVD instead of a bolt? An EVD can also measure ICP, but it has the added benefit of diverting CSF. And so if I have a TBI patient who I want to measure ICP, but they also have hydrocephalus, an EVD may be a great option. Or if I have a TBI patient who I'm measuring ICP and I'm having a hard time managing the intracranial pressures and I want to reduce the CSF volume in order to lower ICP, EVD may also be a good choice for that. And so these are common considerations when thinking about placing a bolt or placing an EVD for a TBI patient. I commonly get asked, how does an EVD work and what are the things to think about when placing an EVD? So I'm going to draw my TBI patient. Here are the lateral ventricles, the third ventricle, and the fourth ventricle. The lateral ventricles are connected to the third ventricle by the foramen of Monroe. The third ventricle is connected to the fourth ventricle by the cerebral aqueduct. And so commonly, when we place an EVD, It's placed in the frontal horn of the lateral ventricle. The EVD is connected to tubing, which is then connected to a drip chamber that's leveled with the tragus or external acoustic meatus. Now, the neurosurgeons who place the EVDs will place them in the frontal horn because not only is this an easy access to the ventricular system, because when placing a foreign object into the brain, you want to make sure that if there's a complication like a tract hematoma, that it happens in a part of the brain that's less eloquent than other parts of the brain. And so it's not uncommon to choose the non-dominant hemisphere, which is the right hemisphere, and the frontal lobes in this location because they are less eloquent than other parts of the brain where you may be able to put a drain in. And so they're commonly placed in the frontal horn. And the EVD has fenestrations along the distal tip to promote drainage. And as I mentioned, the tubing comes into a drip chamber and it gets leveled to the tragus here. And so a common setting for the EVD is 10 centimeters water. This is a common setting that we'll set an EVD to. And all this does, and all this says, is when the intracranial pressure goes above 10 centimeters water, fluid will drain out of the ventricular system into the drip chamber. Now, important to note, there are stopcocks here and valves that prevent, if the pressure is lower in the brain, the fluid from the drip chamber to go back into the brain. That won't happen. It's only when the pressure in the brain is higher that fluid drips. And so it's very simple. It's not too complicated. So what is a normal intracranial pressure? If an EVD was placed in me, important to note that a normal ICP is generally less than 10. So if I was standing here and talking to you guys, the EVD would not be flowing. And if the EVD was set at 10 centimeters water, nothing would be coming out. The circumstances in a normal patient that CSF may flow out of an EVD are if they are sneezing or valsalvaing, or if you stand and make the EVD lose that leveling that it initially had. Those are circumstances that CSF may drain in a normal patient. However, in a brain-injured patient, ICP can be elevated up to 20, 30, and even higher. And so when that happens and the pressure is higher, it will cause CSF to drain. And that's an important part about how EVDs work. If the external ventricular drain is draining too much CSF and you're worried and you have slit-like ventricles, you can always increase the resistance of the EVD. And in those circumstances, sometimes what you'll do is you'll increase it to 15 centimeters water or 20. Or if you have hydrocephalus and you're not draining enough CSF and you want to lower the resistance, you can lower it to 5 centimeters water. And this will allow more CSF to drain. Important to note, if you have slit-like ventricles and over-drainage, it can predispose to tearing of the bridging veins and possibly a subdural hematoma. And then for patients with hydrocephalus, it's important to be thoughtful and mindful about the amount of CSF drainage to make sure that that problem can be treated in a timely manner. You generally don't want hydrocephalus to linger on for days. And so when placing an EVD in a TBI patient, the primary objective is to measure ICP, and we get the added bonus of CSF diversion, as listed here. I want to contrast placing an EVD for a TBI with other disease states like communicating or obstructive hydrocephalus. Important to note that when an EVD is placed for hydrocephalus specifically, we commonly keep the EVD in place until the hydrocephalus has resolved, and then we'll embark on a weaning process. If an EVD is placed for TBI specifically for ICP monitoring, we'll consider weaning or removing the EVD when we're less concerned about the ICP being elevated, or when CSF diversion is no longer needed. Tier 1 treatment strategies for ICP include positioning the neck midline and avoiding neck compression. This allows appropriate drainage from the jugular veins and prevents any backflow or stagnant flow from the jugular veins. This can also happen if a C-collar is too tight. So you want to make sure when a C-collar is positioned, it's positioned and measured appropriately so it's not too tight on the patient. You want to control agitation and treat pain. And then you want to make sure the head of the bed is greater than 30 degrees and avoid hypercapnia. So in Tier 1 strategies, we may not be aggressively hyperventilating the patient, but you can make sure that the PaCO2 is between 35 and 38. These are common things that we'll do in the emergency room or during admission to the ICU to ensure that we're appropriately making sure ICP is controlled and treated. If the Tier 1 strategies are unsuccessful for treating ICP, then we will progress to Tier 2 strategies. Important to note, in this tiered approach to ICP management, you commonly want to exhaust all of the Tier 1 strategies before you go to Tier 2, and same with Tier 2 to Tier 3. When ICP is elevated, specifically in TBI patients, what we can consider doing is sedating the patient to lower the ICP. And why I emphasize the difference between TBI patients is TBI is often a generalized disease. While there can be mass lesions that may need surgery, we're commonly seeing patients with diffuse injury. And when we're embarking on a plan of treating ICP and you want to think about whether the neuro exam is useful or not, if there's no mass lesion, I may not necessarily need to follow the neuro exam as closely, as is commonly the case with TBI. So in these patients, I can consider sedating them. And my first-line choices for sedation include propofol with fentanyl. And I commonly choose a sedative with an analgesic. I choose propofol as my sedative because it can reduce the cerebral metabolic demand. And I choose fentanyl because not only does it treat pain, but it acts synergistically with propofol, and it can reduce my dose of medication for both of these. I'll commonly start with a RASS goal of -2, and then I'll titrate up as needed to get my effect for ICP. Again, I want to contrast this with other diseases and other patients who may have ICP monitors like ICH or subarachnoid hemorrhage. Often in those other patients, we may need to follow the neuro exam much more closely to make sure patients don't emergently need to go to surgery. And anyone in that category, I would avoid sedating as a Tier 2 strategy and consider saving this until after discussing a plan with neurosurgery. Other Tier 2 strategies that you can consider is osmotherapy. Mannitol, 20% can be used to treat ICP, and I'll commonly dose it at 1 gram per kilogram. There is a dosage range of 0.25 milligrams per kilogram up until 1.5 milligram per kilo. When I'm using mannitol, I want to make sure to get frequent BMP and serum osms. And that's to ensure that my osmolar gap doesn't get too high. And I want to make sure my sodium doesn't get too high or my patient gets dehydrated from the diuresis from mannitol. When I'm using mannitol, I want to make sure also not to use it too frequently. And that's the same with hypertonic saline. Why is that? These drugs work to draw fluid from the interstitial space, and they work best if there's a gradient. And so if there's a bigger gradient with my osms or sodium levels, I'm going to get a bigger effect from these medications. Versus if I'm using them too frequently, I may not get that gradient that I'm looking for to reduce the ICP. If I need to schedule the drugs, I'll commonly schedule them every 6 hours. And if I'm using them to treat ICP, I need to evaluate what is the benefit versus risk of each subsequent dose. The other alternatives for osmotherapy include 23.4% saline, and this can be dosed at 0.68 milliliters per kilogram, or 5% saline, which can be dosed at 3.2 milliliters per kilogram. When I'm using hypertonic saline, I want to make sure to check BMPs or sodium every 6 hours, and this is to avoid elevations in sodium that may be harmful. So anytime a sodium goes above 160, it's an independent marker of mortality. So when I'm using hypertonic saline, I want to make sure to reduce the risk of the sodium getting that high to cause harm. Mannitol can generally be given through a peripheral IV safely. However, if we're using mannitol for a prolonged period, I'm going to place a central line for safer use. 23.4% saline always needs to be given through a central line, and 5% saline, like mannitol, can safely be given through a peripheral IV. However, if I'm going to be using this for a prolonged period, I'm going to place a central line to avoid any harm. Finally, for the Tier 2 strategies, you can consider trial of mild hypercapnia or hyperventilation. And in this range, you could consider the PCO2 goal of 32 to 35 millimeters mercury. Tier 3 strategies. Now, Tier 3 strategies I commonly refer to in the ICU as salvage strategies. So before I embark on any Tier 3 treatments, I want to discuss my options with neurosurgery. You want to discuss CSF diversion or decompressive craniectomy. And if the patient has already had those or is not a candidate for those, those are the circumstances you may jump to the Tier 3 strategies. However, you really do want to pause and have a collaborative discussion with your colleagues in surgery before embarking on these Tier 3 strategies, mainly because of the risks associated with using them. So what are the Tier 3 strategies? Well, therapeutic hypothermia can be an effective modality for lowering ICP, and how we'll commonly employ this in the ICU is we'll place an intravascular cooling catheter or an esophageal cooling device, or you can consider surface cooling, and we'll commonly titrate stepwise to see if we get an effect. And so we'll start out with a goal of 35 degrees Celsius, which is 1 degree Celsius below normal, and we'll see if there's an effective lowering of the ICP. If not, we can drop it by 1 degree Celsius until we achieve the goal. I'll usually stop at around 33 degrees Celsius. If hypothermia does not work to lower the ICP, you can consider weaning off because the side effect profile of hypothermia can often be problematic in these patients. Consider that you may have a higher incidence of pneumonia, predisposition to bradycardia, and electrolyte abnormalities. And so if it doesn't work, you can consider weaning off very quickly. Another option for Tier 3 strategies is a barbiturate coma, and this can be achieved with pentobarbital or phenobarbital. When we do this, we're using these medications to essentially induce electrocerebral silence. And so we use these medications in conjunction with an EEG in order to reduce the metabolic rate of the brain so much in order to lower the ICP. We'll commonly use these medications and titrate for the EEG, not necessarily for the patient. So what we'll titrate for is 1 spike per page. And in doing so, we can ensure we're not over-sedating the patients with barbiturates, as the half-life for these medications is often over 4 to 5 days. And so you definitely don't want to over-sedate the patients with barbiturates, because once you stop, the patient may still have barbiturates on board for many days. And so it may take many days, if not a week, for the patient to wake up once this is stopped if the dosing is not appropriate. So again, when we're using it to titrate to an EEG of 1 spike per page. If you see 2 or 3 spikes per page, you can consider increasing the dose. If you see no spikes per page, we would consider either lowering the dose or holding the medication altogether until that spike comes back. And then finally, for Tier 3 strategies, you can consider a trial of a paralytic. This will commonly only work if the patient's moving or having shivering that's leading to intracranial pressure elevations. So I'm not using this if a patient is motionless or still. However, if a patient is moving despite sedation or shivering, then you can consider giving a single-time dose of rocuronium and seeing if there is any effect on the ICP. And if there is a sustained effect, you can either consider redosing the IV medications. You can give rocuronium 1 time, or you can put the patient on a drip at that point. And then anytime I'm employing a treatment strategy in a tiered phase, if I'm escalating in one way, I'm also weaning the strategies in the same way. So I'm often going to wean the Tier 3 strategies before I start weaning the Tier 2 strategies, and then I'll wean the Tier 2 strategies before I wean the Tier 1 strategies. Now, if there's a side effect from one of the interventions, like your sodium is 170, sure, so let's stop the hypertonic saline and make sure that the patient is having a normal sodium. But in general, you want to have a stepwise approach up and a stepwise approach down. Some other TBI treatment basics. We do not recommend routinely administering steroids for TBI patients, as it's been associated with increased mortality. We do not routinely prophylax TBI patients with phenytoin or valproic acid, because similarly, it's been associated with worse outcomes. Along these lines, we do not prophylax with induced hypothermia to reduce ICP, and we don't prophylax with barbiturates to prevent ICP elevations. We use hypothermia and barbiturates really as Tier 3 strategies once ICP is already elevated. And then you want to avoid hyperventilating the patient for prolonged periods. And so if you have a patient after 24 hours who's still being hyperventilated, at that point you want to consider weaning off the hyperventilation strategies in order to make sure that there's normal gas exchange. Keep in mind that hyperventilating too aggressively may cause narrowing and vasoconstriction of the cerebral vasculature, which may not be good for cerebral perfusion. So you generally want to avoid doing this for too long. If you want to do additional reading about TBI, I would highly recommend reading the Brain Trauma Foundation guidelines. And there's a lot of seminal papers in TBI, And I've listed some here that you guys can consider reading. The Best Trip Study, Boost 2, DECRA, Rescue ICP, and the Crash 3 study. In summary, be sure to classify TBI patients based on imaging, GCS, and whether they have blunt or penetrating trauma. Consider a systematic treatment approach to ensure consistent care, and escalate treatment for ICP in a tiered approach. I want to thank you guys for tuning in. Have a good day.